Hey guys, it's Dr. Linville. Happy to be back to go over elbow and forearm kinesiology with you guys. So let's get right into it. The objectives are to understand the articulations of the elbow and the forearm, as well as their purpose in rehab interventions and manual therapy techniques. I want to review the anatomy of the elbow and forearm and their relevance to kinesiology. Understand the osteo and arthrokinematics of the elbow and forearm, and learn about common musculoskeletal injuries in the elbow and forearm complex. So as an introduction here, it should be known that the elbow is an innately stable joint. There's not a tremendous amount of mobility here when compared to the spine or the scapula or the glenohumeral joint even. It's thought of as a hinge joint. However, there are 3 joint articulations within this elbow complex, and if we add the forearm in, we'll see that there's a 4th as well. The joints and muscles of the elbow complex are meant to serve the hand, and what we mean by this is, if it wasn't for the elbow, we would just have 2 poles coming out of our shoulder. The elbow allows that hinge motion as well as the rotational component in the forearm to allow the hand to get to where it needs to go for functional use. This includes eating or scratching the top of your head or so on and so forth. So we begin our anatomy review by looking at the bony anatomy here and looking at the joints and the arthrology. So the elbow and forearm complex is comprised of 4 joints. 3 are proximal and 1 is distal. The humeral ulnar joint, the humeroradial joint, the proximal radial ulnar joint, and the distal radial ulnar joint. And we can see those in this depiction on the right. You can see how congruent those surfaces are, and there's not much space in between. Here are some pictures of the humerus, and one's an anterior view, one's a posterior view, and one's looking from the inferior surface of it. So if we go to the anterior view, you'll notice that these red outlines here are where muscles originate. So muscles start there. And usually what we see here is the distal part of the humerus is the muscles go to the forearm or the ulna or the radius. So you'll notice all of these muscles here are ones that we will go over in your anatomy class, and you'll be able to palpate and dissect and all those sorts of things. But I do want you to notice the capitulum and the trochlea, and the reason I do is because that's where the radius and the ulna articulate with the humerus. And you'll notice that there's a slight angulation there. There's a lateral deviation. The medial side goes down a little bit further than the lateral side, and that will play into some of our carrying angle and things we'll go over later. The posterior view, or that middle picture there, you'll see the greatest muscle that sits on the posterior humerus is the tricep. And then you'll notice the olecranon fossa, where the tip of the olecranon or the tip of the ulna will sit in full elbow extension. If you look at the inferior view, you'll notice that the capitulum is spherically shaped or ball shaped, and then that the trochlea is almost seashell shaped or hourglass shaped. And the main thing is, though, it has a groove in it, and that helps the congruency of this joint. Here we're going to look at the radia and ulna and its anatomy. If you look at the anterior view picture, you'll notice the olecranon process is the most superior thing in the picture, and you can see it's a giant cup-shaped object or C-shaped object, which you can tell that it's not quite 360 degrees around, but it's probably about 270 degrees. So that's going to make for a very stable joint. If you look at the radius, you'll see the words labeled heads. That's the radial head there. And then if we look at from a superior to inferior view, you'll notice that it's actually hollowed out almost like a cup. And that hollowed out portion is called the fovea, and that fovea is what articulates with the capitulum of the humerus. And then if we look down here, you'll notice the gray structures will be where muscles insert on, usually coming from the humerus, and then the red outlines are where muscles originate. You also notice at the bottom of the picture here the distal radial ulnar joint, and I want you to take note of how the concavity changes. So in the proximal radial ulnar joint, the ulna is concave, and then at the distal radial ulnar joint, the ulna is convex. So we'll get into that later in our joint mobilization topic. You can see the same thing for the posterior side as far as where muscles insert or originate, but I want you to take note of the interosseous membrane, which helps with force transmission. We'll get through that later as well. So this is just touching on some anatomical reviews that we'll dive into in more detail as we move along. Here's a close-up of the ulna, and I'll have you look at the lateral view here. You can see that crescent-shaped trochlear notch and how it would sit perfectly within this trochlear groove here. And then you'll notice the radial notch where the radial head sits, and then the coronoid process, which eventually will sit into the coronoid fossa during full elbow flexion, rather. The other thing I want you to notice is the radial head here, and here's a nice shot of the fovea, but the annular ligament encapsulates the radial head so that it prevents the radius from dislocating away from the ulna. So we've kind of touched on this with our anatomy, but let's review one more time. The articulating surfaces of the humerus are the trochlear and the capitulum, but the trochlear is an hourglass-shaped structure and articulates with the ulna, and the capitulum, sometimes spelled as capitellum or pronounced as capitellum, is spherically shaped and articulates with the radius. If we look at articulating surfaces of the radius in the ulna, on the ulna it's the trochlear notch, which is a deep semicircular concave surface, and on the radius it's the head of the radius, which is a cup-shaped concave surface. So, the articulation of the humeroulnar joint. So this is the articulation between the ulna and the humerus, and it occurs primarily as a sliding motion. The ulnar trochlear ridge on the humeral trochlear groove. Those are the two structures that articulate on each other, and we can already see that here. The longitudinal crest or the trochlear ridge right inside the trochlear groove here. So in full extension, motion is stopped as the Olecranon process of the ulna enters the blank of the humerus. I'll have you guys look that up and we can answer in class. And then in full flexion, motion is stopped as the trochlear ridge slides along the trochlear groove until the blank reaches the coronoid fossa of the humerus. Let's go ahead and look that up for me. If we look at the humeroradial joint in the articulation, the capitulum of the humerus, which is convex, articulates with the radial head of the radius, which is concave. In full extension, there's actually no contact between the joint surfaces. There's slight gapping there. But in full flexion, the rim of the radial head slides in the capitulotrochlear groove and enters the radial fossa at the end of the flexion, or as the end of the flexion range of motion is reached. If we look at our radial ulnar joints, first we'll look at the proximal radial ulnar joint. And this is a nice schematic over here. It gives you kind of a mechanical view of what this joint sort of looks like with the radial head and the ulna and how they articulate. But the radial notch of the ulna is concave and articulates with the head of the radius, which is convex, and then again it's surrounded by that annular ligament. The disto-radial ulnar joint, the ulnar notch of the radius is concave, articulates with the head of the ulna, which is convex, but this joint also articulates with the articular disc of the wrist, which is, you'll get into the hand section, but there's something called the TFCC, which is the triangular fibrocartilage complex, and that can be injured through falling on an outstretched arm or twisting motions or things like that. But if you look at the picture here, this might help you visualize of what pronation and supination does at that radiocapitular joint. It almost is like spinning on a door handle on the long axis of itself, similar to what your forearm goes through. The joint capsule of the elbow is a large, loose, and relatively weak structure. It is very sturdy laterally and medially because of the medial and lateral collateral ligaments. However, anteriorly and posteriorly, it's pretty weak. And in cases, the three proximal elbow joints rather, and it's in cases synovial fluid to help with joint articulation. You'll notice that the anterior capsule is located here and it has some of these folds and almost like string-like projections there, which help. They get taut in elbow extension and they get loose with elbow flexion, so that you can go through the full range of motion. So ligaments of the elbow, and this goes for most hinge joints, including the elbow, but most hinge joints have what are called collateral ligaments, and they surround the medial and lateral portions of the joint to provide increased stability. So we see this in the knee, we see this in the hinge joints of the fingers, and then as far as the elbow is concerned, there's the medial, or we'll refer to as the ulnar collateral ligament, and then the lateral collateral ligament complex, as well as the annular ligament, which we've kind of already touched on. So the UCL, or the ulnar collateral ligament, its primary role is to restrict what type of motion at the elbow. I'll ask you guys in class. It consists of three parts. They're referred to as bundles. So this one ligament has three parts referred to as bundles. One is the anterior bundle, or anterior band. Two is the posterior band, and three is the transverse or oblique band. You can see those on the picture to the right. We'll look at that closer up in a second. Just like all ligaments, there's mechanoreceptors densely packed within it. This is to help with proprioception, but you have things like Golgi organs, Ruffini terminals, Pacini corpuscles, and free nerve endings. All those things help with proprioception and pain and sensation. For that last bullet there's one of the bundles that's primarily the ligamentous restraint for valgus stress. Valgus stress is what happens to elbows during the throwing motion. So from 20 to 120 degrees of elbow flexion, the anterior band or anterior bundle is the primary ligamentous restraint, and this is the one most injured during repetitive throwing, like all our major league players. Here's a close-up, so you can pause it here and kind of look at the anatomy if you'd like. So functional summary for the UCL: it stabilizes against blank torques at the medial elbow. I'll have you guys answer that in class, remember. It limits extension at the end of the elbow extension range of motion. It guides the joint motion throughout flexion range of motion. It provides some resistance to longitudinal distraction of the joint surfaces, so it helps keep the joint congruent. The lateral collateral ligament complex, it is located on the lateral side of the elbow, of course. It restricts blank force of the elbow, and also secondarily it maintains posterolateral stability. It's made up of several ligaments, and those are the LCL, or the lateral collateral ligament, the lateral ulnar collateral ligament, and then also the annular ligament. It is a fan-shaped structure that extends from the lateral epicondyle and blends with the annular ligament of the radial head. As we mentioned earlier, the annular ligament encapsulates the radial head, creating stability at the proximal radial ulnar joint. Here's another close-up that you can pause and take a look at the anatomy here. You can notice the blending of these ligaments. So a functional summary for the LCL, or the LCL complex: it stabilizes against blank types of torques. It would be varus torques, because number 2 gives you that. So it stabilizes against a combined varus and supination torque. It reinforces humeroradial joint and helps provide some resistance to longitudinal distraction of the articulating surfaces. It stabilizes the radial head, thus providing for a stable base for rotation with that annular ligament. It maintains posterolateral rotary stability. So if someone dislocates their elbow, it's usually because the LCL has been torn and the radial head is kind of supinated and shifted posteriorly out the back lateral part of the elbow. The LCL prevents subluxation of the humeral ulnar joint by securing the ulna to the humerus, and it prevents the forearm from rotating off the humerus in valgus and supination during flexion from the fully extended position. Now we'll talk about the interosseous membrane. We touched on it earlier, but it's a taut connective tissue located between the radius and the ulna. During rotation, the interosseous membrane prevents the radius and ulna from splaying apart. So without this taut band, your muscles would literally pull these two bones apart from each other. It protects the proximal radial ulnar joint by transferring some of the compressive loads at the distal radius to the proximal ulna. And we'll go over a picture in just a second. If you notice here, we'll just say this is a gymnast that's got to do a lot of back handsprings or things on their hands, handstand walks. You'll notice that the radial, the distal radius is a much larger bone or bone segment than the distal ulna. So when the hand makes contact with the ground, force is primarily transmitted through the distal radius. And then it transfers energy up the radius until it gets to, on this picture, number 2. And when it gets to picture number 2, force is then transmitted actually through the interosseous membrane, through the ulna, and then up the larger part of the ulna here into the humerus and so on. So it protects the radial head from getting fractured or from that compressive force really pushing in the capitulum there. Muscles of the elbow and forearm. This is pretty vast, and we won't go over all the nerve innervations and things of that for this lecture. You'll go over that in anatomy as well as when we do differential diagnosis in musculoskeletal 1. But there's some common things that these muscles do include flex, extend, and rotate the forearm and elbow. And then a lot of the wrist musculature is up near the proximal forearm, including our wrist flexors and wrist extensors. And we'll look at our picture here. This is a pretty cool drawing. It shows you how interwoven everything is. And when you're studying anatomy, it's pretty amazing to know that all these structures are working in concert with each other to allow the hand to be as mobile as it is. If you want, you can pause this here and then go over some of the musculature. If you don't know one, look it up. So the elbow actually does not have a straight line, horizontal axis of motion. It's actually, as we touched on earlier, the medial side of the humerus actually goes down further, is longer in essence than the lateral side of the humerus, and that creates this lateral deviation at the elbow. So typically it's seen to be between 5 and 15 degrees. This picture is depicting 4 and 8 degrees. But if you look at the radiograph on the right, you'll notice the axis of the ulna, and then the long axis of the the long axis of the ulna and the long axis of the humerus creates an angle of about 15 degrees. It would seem there. If you also look at the axis of motion for the forearm, it goes from the radial head to the ulnar head, so there's this oblique axis here, and it allows your ulna and radius to rotate while maintaining its orientation in space. But this lateral deviation is what we call a cubital valgus, or it's also known as someone's carrying angle. And normal carrying angle is between 8 and 15 degrees. Males, it's usually 5 to 10. It's a little less, and then women, it's usually 10 to 15 degrees. And they believe that is the case because women have wider set hips. They also tend to be shorter than men. So if they're shorter, they have to clear their hips more, so they have a little more deviation there. But if we look at the 4 pictures here, normal carrying angle is as those degrees we mentioned earlier. If they have anywhere greater than 15, we usually consider that excessive cubitus valgus. That can create some injury, repetitive use injuries there, if because of really the joint isn't as stable as it should be. And then cubitus varus and gunstock deformities are two things that happen if the orientation is actually medial, which you don't see a whole bunch. Carrying angle, continued here. Cubitus varus, as we looked before, is the medial angulation of the elbow. The carrying angle disappears when the forearm is pronated and the elbow is in full extension or full elbow flexion. So you can try that right now. During elbow flexion, when you're in that anatomical position, the carrying angle disappears usually around 30 degrees of elbow flexion. So you can try that as well. So this is usually just seen around full extension with the forearm supinated. The osteokinematics of the elbow, normal range of motion of the elbow extension is anywhere from 0 or neutral to 10 degrees of hyperextension. And elbow flexion is anywhere from 120 to 150 degrees, which would create a total arc of motion of around 160 degrees. Similarly, we see a total arc of motion of around 150 degrees with the forearm rotation. So supination is usually from 0 to 85. Forearm pronation is usually from 0 to 70. Now let's get into what might be a little more difficult for people to understand. That's the arthrokinematics of the joint here. And so we'll start on the very left under that diagram A. And this is a picture of the elbow joint in full extension. You can see that's in full extension because the olecranon is sitting in the olecranon fossa here. But when it's in full extension, all these structures on the anterior side here are taut or tight. That means the skin, the muscles, the flexor muscles, the anterior capsule, and then also the MCL and the anterior capsule as we mentioned before. If you were to look on the lateral side, you notice the lateral collateral ligaments were also taut in this position. The posterior capsule and the extensors are not taut, they're loose or lax, and that allows you to get this full extension. If we were to go to full extension into full flexion, the ulna has to roll because of the concave rule, but it also has to slide to get into the coracoid notch here. At the same time, the flexors, this is in full flexion, the flexors are loose because they can't contract any further, and then the anterior capsule there is loose as well. As you can see, this bunched up anterior capsule kind of creates an accordion effect. The posterior capsule becomes taut, the extensors become taut, the ulnar nerve, which runs behind the medial epicondyle, becomes taut, and then the MCL becomes taut posteriorly. Here's some other schematics or drawings of what the elbow does arthrokinematically. The ulna and radius glide posteriorly, or they glide anteriorly. This is mainly the radius here at the or the humeroradial joint. And then if we look at the proximal radial ulnar joint, if we're going to go into forearm pronation, there's an anterior rolling of the radial head, but at the same time there's a posterior glide. So that's going to be important to realize when we get into our joint mobilizations. What would help forearm pronation? And it would be posterior glides. Posterior glides would help with pronation. If we're looking at the anterior glides, that's going to help with supination. So you can see how when the radial head rolls posteriorly, the anterior it goes through an anterior glide. So if you're performing a joint mobilization in a posterior direction, that would improve not supination, even though it looks like you're pushing the arm into supination. We'll go over that in lab. It would actually work on pronation because of how the joint arthrokinematics work. So rules to apply for joint mobilization. I'm hoping we can go over this in lab. I want you guys to pause it here and look over all of the open and closed pack positions. These are the positions that the joint will most loosely or not rest in for you to perform joint mobilizations to help patients regain range of motion. So you can pause it here. I want you to write this down, and then we'll go over it in class as well. So just a brief touch on some joint mobilizations here. We'll do these in lab. Humeral ulnar joint mobilization. Your patient position is they're supine. The elbow is in the open pack position, so you can see that that elbow is roughly at 70 degrees of elbow flexion. There's two things we'll talk about. That's the scoop method as well as distraction. The scoop method, you literally put your hands in the antecubital fossa here, and you almost try to scoop that trochlear ridge away from the trochlear notch. We'll go over that. And then distraction. Both of these are just for generalized joint mobility. If you throw in some osteokinematic flexion with it, you'll get you can work on flexion range of motion for your manual technique. So humeroradial joint mobilizations, I do my humeroradial mobs here as well as some of my proximal radial ulnar joint mobs here. The patient position is supine. The physical therapist position I've left blank because I want you guys to try to describe that to me. We'll talk about that arm closest to the patient will be the PT's proximal arm, and the arm away from the patient would be the distal arm. So if you could come up with what the patient position is, or the physical therapist position is in that picture. I will tell you that her proximal hand is stabilizing the ulna in the back. I'll show you guys how to do that. And then her distal hand is the thenar eminence of her hand is on the anterior part of the radial head. So she can either use her fingers to cup around the back to provide an anterior glide, or use the thenar eminence on the front side to provide a posterior glide. We've already kind of gone through what anterior glide or posterior glides might improve here on the previous slide, so I want you guys to fill that in relation to the humeroradial joint. You can also do it in relation to the proximal radial ulnar joint. So some examples of common injuries of the elbow. You have, typically what you'll have is traumatic and overuse injuries. So examples of traumatic would be UCL sprain, posterolateral rotary instability, or an elbow dislocation. You can have a distal biceps tendon rupture, and then of course fractures. Overuse injuries include things like medial or lateral epicondylitis or epicondylalgia, as it's known these days, distal biceps tendinosis, little league elbow, or a UCL sprain in throwers, which is a little different than the traumatic version typically. So traumatic dislocations look something like this. Here are all athletes that you sort of know, but you can look at pause and look at each picture here. All of them, they've lost that posterolateral instability, which has created this tragic accident. There's also something called nursemaid's elbow, and so if you have children, I'd advise you not to pull on their arm. You can literally dislocate their radius from the radiocapitular joint with too much distraction. That's not good. Medial elbow pain in throwers. I have a kid pictured here. In the case of throwers, it's something called little league elbow, where the medial growth plate gets some tensile force on it and it creates pain or apophysitis. In a skeletally mature individual, the UCL is much stronger than, the underlying bone is much stronger than the UCL. So what we get there is a tear of the UCL. Usually it happens with micro trauma over time. Sometimes it will occur through a traumatic snap, but most of the time it comes on with time, and patients will just lose velocity on their throws and complain of medial-sided elbow pain. You also have your fractures here, which these are all taken from our lectures in Musculoskeletal 1, which will go way into depth on injury and rehabilitation strategies for all of these. But you have different type of radial head fractures, usually due to compressive forces, and then there's some examples of how they would fix those things. And then we have the Monteggia Fracture, which is radial head dislocation with an ulnar fracture. And they also see how you could surgically fixate that. Then you have your Coronoid Fracture. as well as your Olecranon fracture. So if we go back, you'll see how they would fixate that and this one here. So with that said, I'll be glad to answer any questions that you guys have in class. If there's anything that's unclear, please write it down. We'll be happy to touch on it with everyone. Thank you for your time and your patience.